the final diagnosis. And so initially you should start with a prostaglandin infusion if the sats dropped below 70, and then you consider the echo as soon as possible, because we know all of us know that the prostaglandin infusion is not a safe drug. It saves the baby, but it's not safe drug to use it without precautions, because we know that in higher doses this drug will lead to apnea, and we will need ventilation, and also it lead to hypotension because it's a vasodilator drug, and it lead to an edema, subcutaneous edema. So, and making the lung more wet with increasing the flow to the pulmonary circulation. So it ends with the flooded lungs. It favors the infection. So it's not, although it is a saving drug. This drug saves the life of the baby, but we shouldn't use it without precautions, and we should use it and as soon as possible get the final diagnosis, to titrate down or to titrate up this medication, and to plan for the next step in the management of this baby. So I'll give some examples from the cyanotic heart disease. Start with the TGA, as it is one of the common cyanotic heart disease, second common cyanotic heart disease after the Fallot, but this present early after birth with critical conditions. So here we can see on the left panel of the clip shows subcostal image. It shows that this is the RV, give the connection to the aorta, and the LV give connection to the pulmonary. So we can see this relation of the great vessels are parallel in this view, which is usually not the normal in the echo. We know the spiral movement of the great vessels. So usually the aorta is going to the right and posterior, and the pulmonary is anterior to the left. If we see this parallel connection of the great vessels to the underlying ventricles, this usually give a high suspicion of the TGA diagnosis. Then we look to the subcostal view, also check the PFO. Here we can see a very restrictive PFO. The flow is very tiny, and the LA pressure is very high, because you know the parallel circulation and the high velocity, and there's high velocity jet. So this baby, you can start the prostaglandin, and you can, if in case of intact ventricular septum and low sats, you can go to the balloon atrial septostomy, which is the Rashkind procedure. So this is the initial management, plus the fluid management and the airway management, and then refer to a specialized center. So one of the critical cases presents early, the patient with a critical pulmonary stenosis. As you have critical pulmonary stenosis, critical pulmonary stenosis means that the pulmonary flow is not enough to maintain the systemic circulation, and most of the blood go through this stretched BFO, as we see in the subcostal view, with the right to left shunt. This blue color is the right to left shunt across from the right atrium to the left atrium. So the systemic circulation is maintained through the BFO, not through the forward flow across the RV. And here we can see a high parasternal short axis view that shows this is the pulmonary valve, this is the aortic valve, this is the main pulmonary artery. Here, as we can appreciate that the pulmonary valve is severely thickened and stenotic with systolic dooming, almost not opening, with a very thin hole like this, with a small jet, and even you can see the flow of the ductus. So in this case, this patient sometimes presenting with a low saturation, you can start the prostaglandin, maintain the circulation, and maintain the pulmonary a good saturation, and then refer for a catheter-based intervention. Here we can see in the lateral view, injecting the RV, we can see the dooming of the pulmonary valve, and here in the lower panel, we can use a balloon pulmonary valvuloplasty, and this is sorted out. Sometimes in these cases, with the bad compliance of this hypertrophied RV, because of the pressure overload, this RV cannot maintain the circulation for the early days after intervention. So sometimes we need to leave the baby on prostaglandin for 5 or 7 days, or sometimes less or more according to the situation. If we are fearing of the complication of the prostaglandin, some institutes do a BDA stent also for these cases to maintain the circulation till the RV being trained on the new situation and pushing the flow across the pulmonary valve. The extreme form of this scenario is the pulmonary atresia intact septum. Why we took the pulmonary atresia intact septum? Because if we have a VSD, so the systemic circulation will be maintained through the VSD. While in this diagnosis, the systemic circulation is only maintained through the ducts, because as we see, this is a 4-chamber view. We can see here that the RV is struggling, cannot maintain a forward flow. We can appreciate the severe tricuspid regurg in the right atrium. And the systemic circulation is maintained by the PFO, and the saturation is maintained by the BDE. So here we can see that there is a moving membrane like a valve. It's a well-formed valve, but it's completely fused without forward flow. And we can see that the flow is maintained through the BDA after starting prostaglandin infusion in this view. And in this case, usually if we have to check that this RV is not supplying the coronary arteries, because this is common in this abnormality. So we do RV angiogram. If we couldn't find any coronaries filling from this RV, which is called RV-dependent coronary circulation, this is a condition you should exclude it before trying to open this valve. In this case, the baby was fortunate. We don't have the RV-dependent coronary circulation, and we targeted the membranous pulmonary atresia, and we perforated with the CTO wires or the radiofrequency wire, and then established the wire in the distal in the lung, or distal through the ductus in the descending aorta, and they go through the valve with balloon dilatation, with a graded balloon dilatation, until we open the valve well. Other cases of the duct-dependent pulmonary circulation lesions, I wouldn't go in details in each one, because we have a number, indefinite number of abnormalities that can go under the diagnosis of duct-dependent pulmonary circulation. But in all these cases, other types rather than the TJA, the critical PS, the pulmonary atresia intact septum, you don't have a definitive treatment initially. So you just palliate them with a BDA stent or the BT shunt, depends on the morphology and the team discussion and the institutional capability of doing which of them, because you should save the baby first. So whatever you can, you are better to do, either a BDA stent or BT shunt, do it for the safety of the baby. But we know that the BDA stent is less invasive, less ICU stay, more controlling through the ICU course than the BT shunt. So in all these situations, you have to identify with the echo the abnormality. You have to identify the shape of the duct. So you have to back one slide. Okay, so here we can see a tortuous duct coming from the undersurface of the aorta. This is a suprasternal view, shows this aortic arch. This is the aortic end of the BDA. This is the BDA joining the pulmonary artery. Here we go to the cath lab after using a small dose of prostaglandin. Sorry, the slide is not working. Okay. So we can see in the angiography here that this is a tortuous duct coming from the undersurface of the aorta. And then finally, we successfully achieved the BDA stent through this complex duct with maintaining blood flow to the post-PE branches and improving the SATs from 60 to like up to 85, 90. Okay. So one of the cyanotic congenital diseases that coming with and defined as a surgical emergency is obstructed total anomalous pulmonary venous drainage. This one wouldn't benefit from starting prostaglandin, so you should be careful with using a prostaglandin. Most of these babies coming with a severe pulmonary congestion, the glass ground appearance on the X-ray, severely distressed. So you should be cautious of using prostaglandin, because if you open the duct and you increase the pulmonary blood flow and you have the pulmonary venous drainage is obstructed, so you get the baby more congested. And this baby, the problem with this baby mostly is maintaining the systemic circulation with this obstructed pulmonary venous drainage, and the lungs is congested, so they coming severely distressed. So be cautious in this diagnosis, especially to use the prostaglandin. Here we can see a cardiac type of total anomalous pulmonary venous drainage with a very small vein connecting the left atrium. This is a case of common atrium. So here we can see that this high velocity jet is the site of the obstruction of the connection of these engorged pulmonary veins behind the left atrium. And the gradient across this jet is around 17 millimeter mercury, which is severe stenosis. And this is the X-ray of this baby. It's markedly congested, showing the glass appearance. And if you appreciate that there is endotracheal tube here, most of these babies need intubation and active management. And it's better to early referral of these cases to a specialized center, aiming a speedy medical and surgical solution. So the second presentation is the circulatory collapse. And in the circulatory collapse, we have the left-sided obstructive lesions is the main lesions that coming with circulatory collapse. The critical aortic stenosis. And in this condition, the LV is severely afterloaded during the pregnancy with this obstructed pulmonary valve. So this baby come up with the LV is markedly hypertrophied with impaired function, as we see in this parasternal long axis view. You can see this LV is not functioning well, and this aortic valve is beaded, thickened, and not opening. So in this situation, the baby is acyanotic. It's coming. You can suspect here the diagnosis that all peripheral pulses are weak. So it's acyanotic baby with diminished all peripheral pulses. The presentation also because of the diastolic dysfunction of this left ventricle that cannot empty its blood. So we have a severe pulmonary congestion, especially if we don't have an ASD or PFO. So we have a congestive heart failure. The lungs is almost white lung, marked cardiomegaly in the X-ray, and it ends with a shock with a closure of the duct. So with the time, the duct become restrictive. So the flow in the aorta is maintained by the duct from the pulmonary to the aorta. So the flow in the ascending aorta and the head vessels and the descending aorta is maintained with the duct, because the aortic valve cannot conduct the cardiac output. In this situation, presents with a circulatory collapse. The second situation that present with the circulatory collapse is acute coarctation or critical coarctation. And also this you can suspect. You have a acyanotic baby coming early, 2 to 3 days after birth at the time of the ductal closure. And this baby coming with bounding pulses in the upper limbs, especially the right upper limb, because sometimes the left subclavian artery supplying the left upper limb is involved in the ductal coarctation and on the area of the coarctation. So you should feel the pulse at the right upper limb and feel the femoral pulses. And the baby is almost acyanotic. So the blood in the lower part of the body is compromised which ends also with congestive heart failure because of afterload on the left ventricle, as same as aortic stenosis. But in this situation, you can differentiate between the critical aortic stenosis and the critical coarctation or interruptions, as the pulses are bounding in the right upper limb and diminished in the lower limbs. And the ECG will show an RVH and LVH, but for sure the echo is a mainstay to identify the diagnosis. Here we can see on this sorry. We can see from the situs, we can see a damped flow in the abdominal aorta. This is a sure sign that there is a coarctation or interruption or hypoplegia. So we have a damped flow, not pulsatile, in the abdominal aorta. This is a Doppler interrogation of this view. There is no preservation of the abdominal pulsatility or the triphasic pattern of the flow. And if you go to suprasternal view, you can see a tight juxtaductal coarctation. It's at the site of the ducts. So with the closure of the ducts, the aorta become more narrow, and the flow to the lower part of the body is sacrificed. And here we can find a gradient of like 75. So the extreme form of the left side obstructive lesions is the hyplastic left heart syndrome with a poor prognosis. This baby presents with acyanotic baby, also have diminished all peripheral pulsations because the lesion is usually combined of mitral stenosis or atresia, hyplastic left ventricle. As we see in this is a 4-chamber view. You can see the mitral valve is hyplastic in comparison to the tricuspid valve. We have very small left ventricle, not apex forming. And also you can see here in the parasternal long axis, the aortic valve is almost atretic or severely stenotic with a hyplastic ascending aorta. In this situation, the circulation is maintained by the hypertensive, the pulmonary hypertension, the hypertensive RV is maintaining the circulation through the ductus with right to left shunt from the pulmonary artery to the either the ascending aorta and the arch and the descending aorta. So with the closure of the ducts, these babies present in severe forms if there is no VSD. So they present with circulatory collapse. The clue is he is an acyanotic baby at the start, coming with respiratory distress. Sometimes there is mild cyanosis because of severe congestion, and here also you can find the all peripheral pulses are diminished. And from the X-ray, you have a cardiomegaly and congestion, and the ECG only shows RVH. There is no LVH in this cases because there is hyplastic left ventricle and the force only for the RV. So going to the management of the circulatory collapse, we have, as we mentioned, the initial and supportive management. You shouldn't wait for a precise diagnosis, especially if you don't have an echo machine around and a specialist around to identify the abnormality. So when you suspect left side obstructive lesions, you find the diminished peripheral pulses, all peripheral pulses, or diminished femoral pulses. So you should suspect an obstructive left side lesion unless the baby is not on severe sepsis or a high another types of shock, septic shock or hypovolemic shock or other types of shock. And the overall the baby is not in a shock state, so you should suspect that this baby would go into a cardiogenic shock. You have a peripheral pulses diminished, either in all limbs or in the lower limbs. Accordingly, you should manage, stabilize the patient, stabilize vascular access, treatment of the shock of the patient is coming shocked, attention to the airway and the breathing, correction of metabolic acidosis, and these babies also should be started on prostaglandin E infusion. And when you start the prostaglandin infusion, you should, as soon as possible, get an accurate diagnosis to see if you are going in the right way or you are taking the side effects of the prostaglandin medication. The definitive treatment for most of the left side obstructive lesions, it's surgical, and it should be planned on a team discussion. If the general condition of the baby after the stabilization is favorable, I mean this baby is not septic, this baby is do not have a kidney affected kidney function or a gut function. So just stabilize the patient, have an accurate diagnosis, go for surgery. If this baby is lately diagnosed and have a poor general condition, either due to sepsis or an extreme low birth weight or a severe low birth weight, so you should bridge to the surgery with catheter-based intervention. And the aortic stenosis, we have the option of the balloon aortic valvuloplasty, although it is not the initial management or the definitive management in our center. Other centers use it as a definitive treatment for the aortic stenosis. But in critical cases with critical aortic stenosis and the poor general condition, it is still an option to relieve the obstruction, to improve the cardiac output, to improve the lower part of the body perfusion, the gut perfusion, the kidney perfusion, and get the baby in a better shape, and then refer for surgical treatment. This is another case of a coarctation, severe coarctation, very tight as we see. And this baby, if we can see in the fluoro, the cardiac shadow is hugely hypertrophied and dilated. We have poor contractility, so we have to go with the caster. This is an injection in the LAO, BA view or slightly LAO. And then here in the lateral view, we used a coronary balloon to dilate this stenosis. And finally, we get a gut flow in the aortic arch and the descending aorta. At least for the time being, this will help the baby to get in a better shape and get out of the poor general condition. And then, because we know that the recoil of the coarctation happens a lot after balloon dilatation, so just follow the patient. If you start to re-stenose again, refer the patient for a surgical repair. Interrupted aortic arch and the hypoplastic left heart, there is no option for the definitive treatment with the caster. It should be surgical, and it's high risk, especially in case of hypoplastic left heart, with high mortality, with inavailability of the nitric oxide in our country. So some centers do a BD stent to maintain the ductus flow to the lower part of the body, serving as a bridge to surgery in poor general condition. Finally, the neonatal heart failure. The heart failure may be congenital, may be acquired, even in the neonatal period. Most of the cases with the congenital heart failure present 2 to 8 weeks after fall of the pulmonary vascular resistance, except for some preterm babies. In some preterm babies, there is an early drop of the pulmonary vascular resistance, especially after managing the respiratory distress syndrome with the Cervanta. The lung get better, and the baby start to present with congestion from a large PDA or from a VSD. So the causes of the congenital heart failure, which presents usually from 2 to 8 weeks after fall of PVR, truncus arteriosus, any single ventricle without pulmonary stenosis. So both circulation are transmitting the same pressure. The systemic pressure is transmitted from the single ventricle to the lung. Any case with large left-right shunt, either VSD, BDA, AB window. Also the arteriovenous malformations like a vein of Galen, anomalous origin of right pulmonary artery, which is called the hemitruncus, the old denomination. And some cases of the fallow with absent pulmonary valve syndrome. In this patient having a severe volume overload because this valve is not stenotic and is severely regurgitant. So you have a volume overload on the RV, and the VSD transmitting the pressure to the lungs, plus the abnormality of the pulmonary vascular structure and the bronchial structure of these babies. So they present sometimes early with heart failure and the chest symptoms. Finally, the LV dysfunction. This is in rare cases of anomalous origin of the left coronary artery from pulmonary artery. In these cases, we have the coronary arteries, the left coronary artery is coming from the pulmonary artery. So initially, while the PA pressure is high and the PVR is high, so it's maintaining the perfusion to the coronary artery to the LV mass. After fall of the pulmonary vascular resistance and drop of pulmonary artery pressure, so it start the steal phenomena. Steal phenomena, I mean that the end diastolic pressure in the ventricle is higher than the pulmonary artery pressure, the diastolic pressure of the pulmonary artery. So this coronary start to steal blood from the left ventricular mass and shunting inside the pulmonary artery. So this ends with a myocardial ischemia and infarction, sometimes papillary muscle infarction and rupture, which ends with severe mitral regurg. And unless this anomaly is addressed, the mortality is like 85% in the first year of life. This is a natural history. The acquired causes of the heart failure, it's mostly acquired ventricular dysfunction and secondary to another causes, myocarditis, especially in case of severe sepsis, cases with dilated cardiomyopathy, septicemia, metabolic causes like hypoglycemia or hypocalcemia, or other metabolic diseases that affecting the myocardial activity, the asphyxia, and the arrhythmia. I just give a short notice on the BDA in the preterm babies. It should be addressed early in any preterm. We know that there is a transitional fetal circulation. So in a preterm baby, we should, if we manage the respiratory distress syndrome and start to find the baby become, after improving the lung condition and the X-ray getting well, and then find the baby start to be tachypnic or distressed again, we should suspect that there is a large left-to-right shunt or intracardiac shunt, either the BDA or the a VSD or another scenario. So if it is a BDA, we should have an echo, and we should start with a medical closure trial of this BDA by fluid restriction management and the medical closure using paracetamol, ibuprofen, indomethacin, unless the medical closure medication is not contraindicated. It should be tried first. And if medical closure failed, we should go either for surgical ligation, or nowadays with the advances of the technology, we have a device closure using soft devices, which is called the Bigelow duct occluder from Abbott. And it is the problem with the duct occluder is being encroaching on the aortic side or encroaching on the pulmonary side. This device, it's put like an embolization device inside the ductus body, not protruded in the aorta, not protruded in the pulmonary. In other countries, they have the portable C-arm of the fluoroscopy. So they get the portable C-arm in the NICU and do it bedside. Finally, my take-home message, management should be initiated with the clinical clues and available tools. We shouldn't wait for the precise and the echo management, echo diagnosis. So based on the hyperoxia test, chest X-ray, your clinical suspicion, you should start the management. Echo is a mainstay and the gold standard tool in precise diagnosis. Prostaglandin infusion, as we mentioned, should be started even before the complete anatomical diagnosis is established in all critical cyanotic newborn. Again, early referral to a specialized center in complex cases where management can be instituted. Cardiac team discussion and decision is the successful key for the management. And thank you.
Informative talk. Here.
So any questions?
No? Okay. Does anyone have any questions? Great. Okay.
Thank you, Dr. Mahmoud, for this elegant talk. I have a question about kids of pulmonary acidic symptom. Why we should exclude anomalous coronary origin before we doing a balloon valvuloplasty.
In the cases of the pulmonary atresia intact septum, you mean?
Yes.
Okay.
As we know,
so we can mute the mic to hear us, right? Okay, so it's a nice question. In these cases, with the pulmonary atresia intact septum, it's different than critical pulmonary artery stenosis. During the embryological development of the RV, in these cases, the sinusoids that the embryological origin of this RV have a communication with the coronary arteries. So sometimes this RV is a closed chamber, and the pressure inside the RV, especially if we don't have severe TR like the case that we present, the pressure in the RV is much more higher than the systemic pressure. So it leads to an abnormal communication with the coronary arteries, even supplying the flow in the coronary arteries. So you need to do an RV angiogram initially to see if the coronaries are filling from the RV, and you need to do an aortic angiogram to exclude that the coronary, if you do an aortic angiogram and find that the aorta is filling the coronaries till the end without communication with this RV and without problem, so it's okay, go for perforation and pulmonary valvuloplasty. If you find communication, marked communication with the RV and the coronary circulation, so if you perforate this valve and open the RV, this RV pressure will drop, so you will get a steal phenomena, and the coronary circulation, it will be sucked in this low pressure chamber, after perforation and opening this chamber. So you will get a massive ischemia because all the coronary flow will be stealed through the opened RV after balloon dilatation. So you should initially exclude what's called RV dependent coronary circulation before going to a perforation and pulmonary valvuloplasty. I hope this answered your question. Are you hear me?
Does anyone have any other questions? Thank you very much for your very interesting lecture. My question is about the use of paracetamol in closure of BDA.
Okay.
That it does not have an anti-prostaglandin effect. Does it have the same results as using brufen to close the BDA?
To be honest, I didn't use the paracetamol a lot in using the BDA, because but we mostly use the ibuprofen unless we have a contraindication, like some babies with a history of G6PD, or some babies with the neuropilitis and the gastric upset. So we use the paracetamol, and there is a paper supporting the use of paracetamol in the closure of the valve in the preterm babies.
I have another question for you.
Go ahead.
Dr. Mahmoud, thank you for the talk. I want to ask about the cooperation between the neonatal units and the specialty centers, the special centers, special cardiac center, as Magdi Yaoub Foundation project. So if the baby is unstable, what is the cooperation with the neonatal units, with the specialty in your foundation? I mean, about, for example, tutory anomaly, pulmonary venous return obstructed. How to get a natal period in coordination with you until stabilization.
I can give you an example. We have a big program accommodating TGA cases from all around the Republic. So usually we advise, usually we were getting the babies on prostaglandin for very long distance from Alexandria to Aswan. We found that a lot of problems happened during transfer, including this or having no good equipments for intubation or for something like this. So nowadays we advise that you can do Erashkind procedure or balloon atrial septostomy bedside or in a nearby cath lab in his government, and then stabilize the baby and transfer them to Aswan Heart Center to be scheduled for the arterial switch operation. We are running a very big project. We have done like 700 cases of arterial switch cases over the past 6 years, and doing like 100 cases per year, and other complexities. We are trying to serve the Upper Egypt especially. So we are accommodating the patient with for duct stenting or for the critical pulmonary stenosis. But the problem is in the transportation from the very long distance governor to Aswan. So we usually advise them to stabilize the baby first. If we can do a bridge interventions or something to save the baby during transfer, we advise the NICUs, I mean the neonatologists from all around the country, NICUs, or the pediatric cardiologists referring the babies to stabilize the baby and then get them to Aswan. This the daily practice that we do in Aswan Heart Center.
Thank you, but it is a big issue because all cardiac specialized centers refuse or couldn't receive any critical neonatal baby until stabilization. So, according to the problems you have mentioned now, I think there should be a telemedicine between Magdi Yaoub Foundation or any cardiac specialized center and those neonatal units, because the resident in the neonatal unit don't exactly have the experience what to do when we face such cases.
Very, very nice idea. I hope that we have the, like you mentioned, the telemedicine or a network to help for at least helping in diagnosis or directing the management until we can accommodate the baby to a proper place to have the management. Here I mentioned that we nowadays we are starting to build up a new a new heart center in Cairo with triple the capacity of the Aswan Heart Center. I think it will be launched by the end of 2023. Hopefully we are serving a bigger volume of the patients and being at Cairo near to the Lower Egypt governorates, and keeping the Aswan Heart Center helping the Upper Egypt and the nearby centers.
المؤتمر ان الموضوع ده يبتدي يحصل فعلا telemedicine.
Thank you very much, Doctor. أنا اسمي أحمد رد, the President of Operations at Telemed International, and we're proud to say that we have a telemedicine unit inside Magdi Yaoub Foundation. We have multiple telemedicine units with Wizarة الصحة, Ministry of Health. We have 50 units already installed and 100 units being installed up until the end of the year. And we have multiple units with هيئة الرعاية الصحية المجالس الطبية المتخصصة. We have 27 units covering the 27 governorates بتوع المجالس الطبية المتخصصة. So what I want to say here is that, and definitely in cooperation with Dr. Adla Al-Alfi, we have multiple units giving consultancies at TeleNACU, like TeleNACU consultancies at the ICUs of neonatals that are already installed right now. We're going to go live with one of them in a couple of minutes.
هي البروبلم اللي احنا فيها دلوقتي، احنا محتاجين تيلي ميديسن مع مجدي يعقوب لوحدات النيونيتال بيريد، النيونيتال يونتس. احنا محتاجين ده لانه في الفتره دي is a critical baby، ومع النايب معش الخبره انه يتعامل معاها، لازم تيلي ميديسن.
الحقيقه طبعا محتاجين جدا خبره السنتر مجدي يعقوب، بس in the same time we need ان احنا ندرب دكاترتنا انهم يتعاملوا مع الامرجنسيز، لان وات ايفر الباور اللي هيقدر دكتور مجدي يعقوب بالتيم بتاعه يوفرها مش هيقدر يغطي السنترز. فلو احنا عايزين نتكلم صح we need to build up our staff to face الامرجنسيز، وناخد الاكسبيرينس the difficult cases من السنترز بتاع دكتور مجدي. هو عامل الحكايه دي مع بورسعيد انا عارفه، وفي مستشفى النصر هم عندهم سنترز فور تيلي محمود.
احنا يعني ديلي بنرد على كل الممكن من استفسارات الناس اللي هي سواء بالتواصل المباشر عن طريق الموبايل او عن طريق التليميديسن. انا I'm not aware بكل يعني التواصل بتاع التليميديسن سبيسيفيكلي معايا، يمكن في حد في السنتر الدكتور وائل عبد العال او حد مسؤول عن القصه دي في السنتر هو اللي اوير بالتواصل ده. ولكن انا اتليست ان احنا بيجي لنا كل يوم حوالي 100 ل 150 ورقه عن طريق البريد، بنريفايز الحاجات بتاعتهم as soon as possible. لو فيهم حالات emergency بن try to contact the patient. Sometimes في برضو يعني a lot of cardiologists around the country، كلهم اساتذتنا وكلهم ناس very professional، بيتواصلوا معانا directly في بعض الحالات اللي فيها نقدر نهلب فيها. But the problem is it's a big volume. The congenital heart disease is the major problem with a big volume that the all centers in Egypt with its I mean nowadays capacity trying to help as much as we can. ولكن الفوليوم beyond the capacity بتاعت السنترز available. So why we start to think about establishing a bigger center at Cairo، يبقى شويه قريب من المحافظات الثانيه عشان نقدر نسيرف مور اريا. بلس بقى منظومه التامين الصحي الجديده الشامل اللي هو هيبتدي بدا في بورسعيد ودلوقتي بدا في اسماعيليه واعتقد في الاقصر كمان قريب. فهيبقى في اكسسنج ل different areas على مستوى الجمهوريه، نقدر ننقل فيها التواصل مع الدكاتره في النيكيوز ونساعد زمايلنا بمعنى صح ان احنا نقدر نخرج من السيتويشن ده. الحاجه الثانيه زي ما الدكتوره عبله قالت ان احنا we have to train our staff ان هم at least الانيشال مانجمنت. as I mentioned احنا بنتكلم في كلوز بسيطه خالص، يا اما ساينوزس يا اما سيركولاتري كولابس. احنا بنتكلم في 2 ايتمز هم اللي محتاجين early او critical management. بعدين انت هتبتدي you should start with a fluid management، start with the ventilation، start with الحاجات البيزك اللي انت بتتعلمها في البيدياتريك لايف سبورت بتاعتك. ولو عندك هاي سسبشن بتاع حاجه كاردياك هتبتدي بروستاجلاندين، و once انت you started the prostaglandin infusion you should try to get as soon as possible an echo diagnosis, definite diagnosis to تقدر I mean to plan for the second step of management and to avoid the complication بتاعت البروستاجلاندين. I'm not addressing ان انت start the prostaglandin for any case خلاص عشان برضو كلامي ما يتفهمش غلط، ولكن I'm addressing that if you have very high suspicion of cyanotic heart disease with hyperoxia test, with the examination, with the peripheral pulsation, with the diminished peripheral pulsation in the case of circulatory collapse, start the prostaglandin and try as soon as possible get an echo diagnosis and then plan for referral or plan for management.
Thank you, Dr. Mahmoud. Thank you. It's a pleasure having you with us. وهنشتغل in cooperation لغاية ما نعمل improvement in the first and second line of doctor, because I think this is the target. إن احنا to raise the quality of our physicians beside the critically ill patients, to do the acute critical management properly, and they can consult for the complicated cases and the step next to that. ألف شكر حضرتك.
Thank you so much, Dr. Abla, for the great gathering and the organization, and also I'm sending my greetings to Dr. Rino here. Nice to have see you tomorrow, and good luck in your presentation. Thank you so much.
طيب هتقطع عليه ده ولا هتعمل ايه؟ ما قلت له كلموه.
Okay. Okay. Dr. Mobley, can you hear me?
Yeah, I can hear you. Can you hear me okay?
Yes. Thank you so much for your time today. We're having a 10-minute delay because we have a live transmission from one of our governors in Egypt for teleMICU. They're currently in the intensive unit, so we're just asking to carry your talk 10 more minutes, if that's
fine. That's not a problem.
Thank you so much. Sorry about that. Okay, so it is our pleasure today to announce the Neonatal Excellence Training Academy. It's a training program based on family-centered neo-baby-friendly system at different levels of NICU using blended educational format. We have a live transition from Said right now. It's teleMICU that we are excited to share with you. نرحب بهيئة الرعاية الصحية وإحدى هيئة التأمين الصحي الشامل، هيئة الرعاية الصحية وهيئة الرقابة والاعتماد وهيئة التأمين الصحي، وهيئة الرعاية الصحية هيئة وريدية لمستقبل الصحة في مصر، لأنها الهيئة المسؤولة عن تقديم خدمات الصحية في المحافظات، ومحافظة بورسعيد أول محافظة انطلقت منها منظومة الهيئة، وقريب قوي هيبقى هتخش جنوب سيناء، في جنوب سيناء والأقصر والإسماعيلية. أول تعاون مع الهيئة من خلال مبادرة ابني بدري ووحدات التشخيص عن بعد اللي بتتواصل مع الجمعية المصرية لأعضاء الكلية الملكية البريطانية لطب الأطفال، وتم التنسيق مع هيئة الرعاية من خلال منسق المشروع بورسعيد وشركة تيليماد لتدريب الطبي على استخدام الوحدات في تقديم حالات الأطفال المبتسرين اللي بتحتاج للرأي الطبي الثاني في التشخيص والخطة العلاجية. معانا أستاذ دكتور رائد حسين مشرف عام على مستشفى النساء والولادة ببورسعيد.
السلام عليكم. أنا برحب بصدر
احنا we are transferring a model for teleNICU today because it's recently started in Egypt, and this is a complementary module with what we have Academy or Natal Excellence Training program, which we have done as a blended education. We do have a training online plus on ground face-to-face training for the skills, and when they need urgent consultation or they need consultancy for any cases, we do it through teleNICU. So دكتور حضرتك كنا امبارح بنتكلم على حالة في حالة البيبي البريماتشور اللي كان عنده respiratory distress. هنكمل مناقشتها النهارده ولا حضرتك عندك نقطة معينة عايزنا نناقشها؟
هنتناقش ان شاء الله في الحالة دي.
المفروض كان في داتا حضرتك هتجيبها لنا، كان في اشعه وايكو.
ان شاء الله.
Been discussing a breathing baby. He was born at 52 weeks and he was well for 3 days, and then suddenly he collapsed and he had severe pulmonary hemorrhage. They managed to give blood, conacune and fluid support, and they put the baby on the ventilator, and they have no reason for that. And we discussed the case, said it can be an underlying patent ductus arteriosus which led to the pulmonary hemorrhage or hemorrhagic pulmonary edema, and it can be an infection and a pneumonia. We discussed it to have an X-ray done and then to have an echo for this baby. So this is the X-ray of the baby, and it shows some evidence of infection or congestion in the lower zone of the lung. What about the doctors?
Hi everyone.
How was the echo finding?
Yes, there is after committee with our professor we found this data after we did what is the cause of the infants discuss
الصوت من عند حضرتك شويه يا دكتور.
اوكي
ايوه الصوت كده احسن.
You got it?
الصوت احسن. حضرتك قول لي الفايندنج بتاعت الايكو.
After the committee
Patent ductus arteriosus or what?
No, there is no ductus arteriosus. There is the pulmonary is unfortunately the pulmonary
بس عايزه تظبط الصوت عند حضرتك شويه.
Okay.
Movement. He's getting abnormal movement. Yes. دكتور محمود البيبي ده كان عنده اي convulsion؟ لا جات له قبل كده يعني؟ الصوت الحقيقه يا جماعه احنا بقالنا for maybe now almost 6 months before we had it with مستشفى العام few sessions وبعدين stopped for a while وبعدين we are restarting again. التالي ميديسن في مصر بدأ ياخد خطوات حلوة جدا. كنا بنعملها مع الخارجة ومع الوادي الجديد ومع النوبة، وعملنا سيشن مع أسوان العام، وعملنا السيشن دي مع بورسعيد، بس بورسعيد الوحيدة اللي كنا بنشتغل تيلينيكيو، وهي كانت براكتس مبتدي جديد. يعني هو كلمني على الحالة دي امبارح الساعة 10 بالليل، وكانت بقالها 3 ايام عندهم وكانت كويسه. انا now مثلا I can help him to tell him there is an abnormal movement. الولد عنده abnormal movement which is not diagnosed by them. فده بيقول ان احنا الانتراكشن اللي بيننا وبينهم ممكن there is an abnormal movement now. You can see that?
Yes.
لا he's getting تاني اللي هي لا البادي شايفه؟ Yeah. Twisting movement. لا مش twisting movement. والوقت both limbs are convulsing. Now we need ان احنا نديله anti convulsant يا دكتور وتشيك ال causes of that metabolically.
We did
He needs to check blood sugar, the serum calcium and magnesium.
we'll check about metabolic disorder for this convulsion and
I think before going to metabolic disorders or inborn error, we need to check the metabolic screen of the baby. We can see the biochemistry, the glucose, the calcium, the magnesium, electrolytes. كان في incident لما جاله البلمونري hemorrhage he was hypoxic for some time.
No. It was good all the time. No suggestive incidents at all. Suddenly exposed to pulmonary hemorrhage. After that, we search about the reason, either cardiac or
Any alternative done on admission? Did you prepare anticonvulsant for him? يشيك البلاد anticonvulsant.
Yes, okay. Now we'll do now. Sure.
حد يعني الدواء بياخد وقت يتحضر يعني. تمام.
Now we're very
So doctor, we need now a management of the acute event اللي حصل معانا suddenly الوقت زائد management بتاع underlying problem. The acute event is a convulsion now which we need to stop urgently now. So we need blood glucose measure. Injection intravenous. عشان الكلر بتاعه also started to change. وبعدين we need to check his blood pressure لان البرفيوجن في اللور لمب برضه مش عاجباني يعني there is البرفيوجن in the lower limb is not linked.
Yes.
And the poor perfusion in the and his pattern of respiration still is not synchronized with the ventilator. ده طبعا سبب الكونفولشن اللي هو فيها فلما انتي كونفولسنت يس اوكي دكتور محمود مش هنتعبكم معانا علشان خاطر you have to deal with the patient with manage status. We'll come back to you once you manage to stop the convulsion to discuss the case again.
Thank you. We have our Dr. Abla. Left to continue. ده الحقيقة is very good model لأن احنا how can we help with telemedicine an acute condition which came suddenly while we are discussing. قدرنا نأسس ال level of perfusion just by NICU. قدرنا نشوف ال pattern of respiration. قدرنا نشوف ال synchronization with the ventilator. قدرنا ندسكاس الحالة على البلمونري hemorrhage اللي حصل للبيبي. It save a lot of health issues خاصة لو الأجهزة دي اتركبت في أماكن ما فيهاش experts. يعني بورصات مليانة ناس experts لكن ده تجربة احنا بنجرب موضوع عشان نقدر نحط جهاز بقى في الأطراف ونحطه في الكرة ونحط اللي محتاجة مساعدة فعلا. ما انا مش عارف بس هو قال لما جه المستشفى عايز يتكلم. ما سمعت في الثاني. نعم. خلاص كده هم خرجوا.
Our next, yes. Dr. Mowgli, thank you so much for your patience and your time today. So on Dr. Nobler. He originates from the Netherlands, where he qualified in medicine at the Erasmus University in Rotterdam. He completed his training in pediatrics and pediatric intensive care medicine in the UK and Canada, and he has been a consultant in PICM since 2001. He has also held a consultant post at the Birmingham Children's Hospital in the UK since 2004, where he specialized in the management of complex neonatal heart diseases. Since 2019, he's actually been an advisor to the PICU at Aswan Heart Center as part of the Magdi Aoud Foundation, and his areas of interest and focus are acute respiratory failure and support, cardiac intensive care, organ donation, and end-of-life care.
بروفيسور رينو ميلدنا تأهل من كلية طب جامعة أريزمس في روتردام هولندا، وتخصص في الأطفال والرعاية المركزة بين المملكة المتحدة وكندا، واستشاري في مستشفى بريمنغهام للأطفال بالمملكة المتحدة، ومتخصص في التعامل مع الحالات أمراض القلب في حديثي الولادة، وحاليا هو مسؤول عن نقل الأعضاء والأمراض وعلاج الأمراض التنفسية والقلبية في الرعاية المركزة للقلب، ومستشار لمؤسسة مجدي يعقوب للقلب في أسوان. Sir?
Thank you very much for the introduction. I'll upload my presentation. Let's see. Can you all hear and see okay? Yeah. Good afternoon to all my friends at Aswan Heart Center. I would like to be for inviting me to speak to you this afternoon on perioperative care of babies operated for congenital heart diseases. So to start with, good teamwork is essential when looking after infants who have undergone cardiac surgery. These infants are on a journey, and the time in the operating room and in the intensive care unit is often the most period of this. And there's a large team of professionals involved in looking after these children. I think the parents at the top here, they'll have a relationship with their cardiologist. We have the team using this, and then we have the intensive care team, and they're supported by pharmacists, and often we need to ENT surgeon, respiratory to help us manage some or an electrophysiology. Unfortunately, I live in an environment where, in a resource-rich environment, so we have dietitians and family liaison nurses and psychologists to support these children and families as well. So it's a large team that's involved in looking after these children. When a child has undergone heart surgery and arrives in the intensive care unit, the first part that needs to happen is a handover of care by the surgical team to the intensive care team. And when I started working in pediatric intensive care, this tended to be not a very organized process. But in the last 10 years or so, there's been some developments into how to streamline this process. And Catchpole and his colleagues from Great Ormond Street in London have done some work on this, which they published And they looked at how Formula One pit stops work, and also how in aviation teams work together to improve safety and quality. And what they did is to break down the process of handover into steps, make sure that as the team from the operating theatre and the patient arrive, the bed space is ready. And first of all, do a technology transfer, get the monitoring, infusion pumps, ventilation, all transfer. Once that's happened, a verbal listen. And it should be Sorry.
We can't see your slides, your presentation slides, if you are. Yeah.
I'll try again, because it should work. Can you see it now? Because I think the share isn't working at the moment. And I have permission to share.
Oh, you still can't see the slides. Is there an option to? Do you see it at the bottom tab?
Yeah, what I'm trying to do is to.
actually not.
So am I? Does someone need to give me permission to share?
Does someone need to give me permission to share?
You should have permission to share. Try opening your PowerPoint slides if that's what you're using to present.
I would have to email them.
No. You open the slides.
Okay, so I'll open the slides. Yeah.
And then click on present now. In the call, in the Google Meet call, and select window.
Oh, okay. Yeah.
Now.
Okay, I think that's working.
Yep. We got to that. Perfect. Yep.
Excellent. Sorry about that. So this is my slide. I was talking about the whole team. So and then on the second slide, I was talking about transfer and handover. And what you want to achieve is a situation where the handover is calm and controlled. It does take time and effort to develop this, but and it needs buy-in from all the team members. So this is from their paper, which gives an overview of how the process works. So phase one is a pre-handover where the ICU team gets information about the patient, set the bed space up, then the team arrives. And first of all, they don't talk to anyone. They set the ventilator, start the monitoring in the ICU, deal with the pumps and the drains and everything else. And once that's happened, and the anaesthetist has done a safety check, and then everybody is there, the whole team is ready to listen. Then in turn, the anaesthetist speaks first, hands over, then the surgeon speaks, and they don't get interrupted and provide relevant information. And they're using an aid memoir to help them to make sure that they go through it systematically. Then there's another safety check, and then the team then discuss the case as a group. You talk about anticipated problems, anticipated recovery, and once the handover is complete and there's a clear plan, then the ICU takes over responsibility for the patient. Oops, get rid of this. And this is an example of a standardized checklist that you can use. You can make your own, it doesn't really matter, but this is one of the examples. So the first part talks about the surgery and the procedure. the bypass times, whether there was antegrade cerebral perfusion, any significant events, and also the echo, whether there was transesophageal or epicardial echo that was done at the end of the surgery. Then summary of all the medications and fluids that have been given, and the latest gas results and other electrolytes, and also the observations from at the point of leaving the operating theatre. And then on arrival, there's what rhythm is the patient in, whether they're paced or not, ventilator setting, chest tubes. So it summarizes exactly where the whole condition of the patient and what has happened in theatre in a standardized way. When receiving a patient after cardiac surgery, particularly when the surgery be done in cardiopulmonary bypass, it's important to understand the effects of cardiopulmonary bypass. And all of you who are involved in care of these infants, I would encourage you to go and visit the operating theatre to see how it works. As you can see from this image here, it's quite a complicated setup with the perfusion machine here at the back behind the surgical team. So there are quite a few pathophysiological effects of cardiopulmonary bypass as the blood comes into contact with the extracorporeal circuit. And first of all, there's activation of the coagulation and fibrinolytic systems. There's also a complement activation and release of kinins. And that causes activation of inflammatory cells and production of cytokines, which creates this loop of an inflammatory response. Complement also activates the endothelium, and there are other things that happen during bypass that will have an effect on the endothelium, including ischemia, reperfusion, changes in flow, so you're dealing with a constant flow rather than a pulsatile flow, and also hypothermia. And all these effects together cause an inflammatory response and increase capillary permeability, and that then leads to multi-organ failure. Now, over the years, bypass has evolved a lot, and there are strategies available to try and reduce some of these effects. And some of the things that have been introduced are miniaturized circuits or biocompatible circuits. Corticosteroids have been used for a long time at the beginning of bypass to try and suppress the inflammation. Ultrafiltration is also used towards the end of bypass to remove fluid and also some of the cytokines. And more recently, people have started to introduce nitric oxide into the cardiopulmonary bypass circuit to reduce the endothelial activation. And also there's a recent interest in sort of targeting certain perfusion pressures during bypass to protect the brain and the kidneys. So on arrival in the ICU, after the handover has happened, initial assessment needs to happen. You should always fully examine the patient, organize investigation, so you want a full biochemical, hematological profile. The patient needs a chest film and an echocardiogram, and then assess the situation in terms of what, for this particular patient, what's the potential for early extubation, or is this a child that's going to have to be kept in the ICU for several days? And also think about the main risks in terms of complications. And these are lesion and surgery specific, and I'll talk to you about that in a minute. Think about things like excessive bleeding, potential for arrhythmias, potential for low cardiac output syndrome, and pulmonary hypertension. And also think about the likely length of stay. Are you dealing with a relatively simple procedure that's gone very well, and would you expect a short stay, or is this more complex? And would you expect a longer stay? It's important to closely monitor the patient at the bedside. So we want to monitor airway and breathing. As a minimum, you should have oxygen saturations, ECG, non-invasive or invasive blood pressure. It's now a standard where we work to use capnography, but it's expensive. Make sure you can do regular gases either at the bedside or in a nearby laboratory. And don't forget, there's also the ventilator at the bedside that gives you information about how the lungs are doing in terms of airway resistance and compliance. Apart from ECG and blood pressure, most patients will have a central line, so you can measure central venous pressure. And for particular surgeries, Sometimes surgeons will place an LA line so you can directly measure the LA pressure, or sometimes the pulmonary artery pressure. Other very useful measurements that you can do at the bedside are measuring serum lactate and also the saturation of the mixed venous blood, and track that as a mark of cardiac output. Measuring urinary output continuously is important as well, and don't forget that apart from diagnostic echo, we can also do functional echo, and particularly we can look at things like fluid responsiveness, filling, contractility, estimated RV pressure, and we can also estimate the systemic vascular resistance and cardiac index. There are ways of continuous neurological monitoring as well, with either continuous EEG or near infrared spectroscopy if it's available. So just going on to lesion-specific considerations. So it is important to have a detailed understanding of the preoperative and anatomical diagnosis. So you need to really understand what was the underlying problem of the child, and also what was the physiology. And we've heard in a previous talk about pulmonary overcirculation when there's large left to right shunts, and children present in heart failure with either large VSD or an AVSD or large PDA, and it's important to know about this. Was there impaired systemic perfusion with left-sided obstructive lesions such as aortic stenosis, coarctation, or hyperplastic left heart syndrome? Or were you dealing with a condition where there was impaired pulmonary blood flow, which is usually duct dependent, such as pulmonary atresia, VSD? And then there's a fourth group of conditions where there's a parallel circulation, and the classic example of that is a transposition of the great arteries. So it's important to understand what was a physiological condition of the child before surgery, and then you need to understand clearly what was a surgical intervention. Are there any known residual lesions? Because they can have an effect on post-operative recovery. And then for each specific condition, there are common post-operative issues and complications. And as we've heard in the previous talk, there's a wide range of different conditions, and there's not time to go into each one of them this afternoon, but it's important to be aware for each condition has specific issues, and I'll give an example of that in a minute. There are some good references that you can use at the bedside, either online from the Cove Point Foundation, or we have at each bed space in our unit, we have a copy of this book, Pediatric Heart Surgery, which is a reference, and it gives you, for each condition, gives you the anatomy, the surgical procedure, and also the common post-operative issues and complications. So just as an example, if we talk about transposition of the great arteries and the patient that's undergone a switch procedure. So pre-operatively, we have a parallel circulation where the aorta is committed to the right ventricle, and the pulmonary artery is committed to the left ventricle, and the blood, rather than being in series, just goes around the lungs and comes back to the left ventricle, and the same with the systemic circulation. So the surgery for this is the switch procedure, whereby the aortic root and the main pulmonary artery are transected and then literally switched. There's obviously a lot of suture lines here on the vessels. It also involves having to re-implant the coronary arteries as well. And often if there's a duct, that will be ligated at the same time. Some of these children present with a VSD, so that will be closed as well. Now, the main complications of this type of surgery are initially there's a risk of bleeding, particularly because there's quite a lot of suture lines. Depending on the timing of the surgery, there's a potential for acute left ventricular failure. Obviously, while before the surgery, the left ventricle was committed to the pulmonary circulation, which is a low pressure system. After the switch operation, the LV is now committed to sort of natural systemic circulation, and it's a much higher pressure system. So the LV has to work much harder. And particularly when children present late, the switch procedure carries a risk that the left ventricle will fail acutely because it just can't handle the pressure load. Because of the coronary re-implantation, there's a risk of coronary obstruction and myocardial ischemia. because the pulmonary artery has been changed in position and has to stretch a slightly longer distance, there's a risk of pulmonary stenosis, and other complications more in the longer term are aortic regurgitation, aortic redilatation. So it's important to be aware of these main potential complications. They don't happen often, but they occasionally will happen, and be on the lookout for them as you're looking after these children. So just to go back to sort of more general principles, so let's talk about cardiovascular management. What we commonly see, particularly after more complicated procedures in infants, is that there's delayed sternal closure. So children come back from the operating room to the intensive care unit with the chest open. The reasons for that can be several. Sometimes it's done electively, particularly after big procedures where there's an expectation that a child will develop quite a marked inflammatory response and quite a bit of capillary leak. And this, leaving the chest open in those situations helps with cardiac and respiratory recovery. If at the end of the procedure there's already a lot of edema, leaving the chest open can help. If there's significant hemodynamic instability or the potential for significant bleeding, it helps to leave the chest open and wait until everything is settled down and then close the chest. It's important to realize that in the retrospective studies that have been done, that there is an increased risk of surgical site infection when the sternum is left open. So you only want to do it for the shortest possible time. This another issue that is always a problem after any major surgery is a potential for bleeding. It's important to correct temperature aggressively in these children, because if cold children the coagulation doesn't work well, and also to correct platelets, clotting factors, particularly fibrinogen with cryoprecipitate. Usually the anaesthetist will work quite hard at the end of the procedure to correct all these things, but there may be ongoing loss of clotting factors and consumption of platelets. So that's something that's important to track. If there's significant bleeding, and usually around 4 to 5 mils per kilo per hour, despite aggressively correcting clotting factors and platelets and getting the child warmed up, the surgical team need to be warned, and the child may need a chest exploration. Other common problems are arrhythmias, and the incidence varies between 15 and 50%, particularly in younger infants and who've undergone prolonged cross-clamp time or who have had deep hypothermic cardiac arrest. Most commonly you see tachycardias, and again, they can be divided up in wide complex, and that again can be ventricular tachycardia or SVT with aberrancy, and it's also important to distinguish between the two because they have different treatments. Arrhythmias are associated with worse outcome, and particularly if there's loss of AV synchrony, that can reduce cardiac output. So it's important to be aware of that. The other type of tachycardia that can develop, which is more common, are narrow complex supraventricular tachycardias, and they can be divided up into automatic or reentrant. And in the automatic group, you have ectopic atrial tachycardia or junctional ectopic tachycardia. It's important to diagnose what you're dealing with the 12-lead ECG, and if you have pacing-wise, you can do an atrial wire study that can help you. It's also important when you run into these difficulties to get support from your cardiologist. If there's VT, it needs to be treated according to APLS guidance, so it'd either be lignocaine infusion or amiodarone infusion, and obviously if the child is hypotensive, it would be a DC cardioversion. SVTs can often be observed if there's no hemodynamic compromise. If there's a reentrant tachycardia, treatments like adenosine cardioversion or overdrive pacing can be tried. The thing with the reentrant tachycardia is they often have a very rapid, sudden onset, whilst the jets usually happen more gradual, so a gradual increase in heart rate with a loss of P waves. For atrial ectopic tachycardias, you can consider beta blocker, but like I said, you should always talk to a cardiologist about this. For jets, it's important to initially correct any electrolyte abnormalities, minimize catecholamine use, and optimize sedation as a first step. And if it still persists after that, you can try cooling down to 36 or maybe sometimes 35 degrees. And then as the heart rate slows down, you can then pace the heart. And another effective treatment is amiodarone. Like most antiarrhythmics, they do suppress myocardial function, so you should always be careful in starting those. And it should always be done in discussion with other members of the team. Bradycardia can happen as well, or sometimes just a sinus bradycardia or a heart block, and generally that's very easily treated with pacing. Now, one of the other complications that can occur, particularly after major surgery, is a low cardiac output syndrome, and it's characterized by tachycardia, hypotension, poor peripheral perfusion, poor urine outputs, and then failure of other organs. What you typically see on the blood gas is a high lactate and an increased extraction of mixed venous oxygen, usually sort of beyond 30 or 40%. And like I said, the children at high risk for this are neonates with complex procedures, any patient that's had a prolonged cardiopulmonary bypass time and cross-clamp times, and also children who've had preoperative heart failure or collapse. And again, this goes back to what we were talking about earlier, is early recognition of the sick child and early stabilization. And when you're dealing with an infant in low cardiac output syndrome, it's important that you distinguish between those children that still have residual lesions that are amenable to surgery that are causing the low cardiac output syndrome. And those could be residual PDAs or residual VSD, over-shunting, or severe valve regurgitation, versus the ones where you're happy that there's been a good repair, there's no significant residual lesions, and it's down to mainly medical treatment to get them through this period. So again, physical examination is important. Echo is important as well, give you important information about the anatomy and the physiology. And when you're dealing with a child going into low cardiac output syndrome, talk to the whole team, cardiac surgeon, cardiology, others, about are there any residual lesions? Does this child need a reoperation? And also, if we're not winning, at which point would we go to mechanical support or ECLS? Keep the child deeply sedated. Often you will also have to keep the child paralyzed, and then tailor the inotropes to the clinical picture. And I would use the inotropes you're familiar with in your unit. We use mainly adrenaline and milrinone. The advantage of milrinone, if you have it available, is it has a lusitropic effect, which can improve diastolic dysfunction. But it's also a dilator, so in some children they tolerate it very well because it drops the blood pressure. If you're in a situation where a child's very vasodilated, we add in noradrenaline and often vasopressin. Once we get to usually around 0.1 mic per kilo per minute of adrenaline and noradrenaline, we add in steroids, like you would do in a child with inotrope-resistant shock. And with the small babies, often a calcium infusion can help as well, just to increase vascular tone. There's a lot of talk about drugs like levosimendan, thyroxine. In my experience, we used levosimendan quite a bit a few years ago, but it doesn't really seem, although it can have some physiological improvement, it doesn't really get children out of trouble. T3 is similar. In my experience, it doesn't really help that much. It's also very expensive. So I think if you really end up on high doses of inotropes and the child is not improving, your next step, if it's available, would be to consider mechanical support. The other thing you need to consider is whether the child needs a cardiac catheterization, and that can either be done ahead of going onto mechanical support or after the child's been placed on mechanical support, or maybe a CT scan. What you want to try, if you've got mechanical support available, it's probably better to use it earlier rather than later. If you wait a long time, high dose inotropes do cause myocardial damage, and also the child will end up in multi-organ failure and will take much, much longer to recover, and the risk of mortality is higher. Another problem that's not unusual is pulmonary hypertension. It can be a cause of acute deterioration or sometimes cardiac arrest in certain children. There are patients who are predisposed to it, so any condition where there was a pressure load to the pulmonary arterial system preoperatively, such as truncus, large VSD, AVSD, AP window, PDA, they're all at risk of developing pulmonary hypertension in the postoperative period. Or in conditions where there was impaired outflow from the pulmonary arterial tree, such as obstructed TPVD, mitral stenosis, or in hyperplastic left heart, where there was a restrictive atrial communication. And some in transplant centers, they'll see patients with pre-existing pulmonary hypertension. There are also other children who are at risk of pulmonary hypertension, such as children with Down syndrome or obstructive sleep apnea. So the reason why these children can suddenly develop a pulmonary hypertensive crisis is because they have a very reactive pulmonary vascular bed. And that reactivity does take some time after the surgery to settle down. And typically they present with acute right ventricular failure, tricuspid regurgitation, and a raised CVP, and a decrease in cardiac output and myocardial ischemia. So they look acutely unwell with a high CVP. And also, interestingly, what you often see in these children is that they develop increased airway resistance. It's not really clear why that is, but there seems to be some component of acute small airway disease in these children. So how do we treat it? Initially, the main thing is to avoid any stimuli that can provoke it. So where the children are predisposed to potential pulmonary hypertension, you want to gradually wean sedation after surgery, and also things like airway suctioning need to be done gently. You want to avoid hypercarbia, and you want to maintain good oxygenation. Oxygen is a pulmonary vasodilator. If you're struggling with pulmonary hypertension, if it's available, you can give inhaled nitric oxide or inhaled iloprost or prostacyclin. And the other drug that may be available is IV sildenafil, or you could also give it orally if you need to. A couple of other important selected emergencies that can happen to mention is, first of all, cardiac tamponade. Again, it's something you should always anticipate as a possible complication in anyone who's had cardiac surgery. And usually if these patients present with tachycardia, fall in blood pressure, and a rise in CVP, and often you can see blood oozing from the dressings, or sometimes trickling along the drains. What's not unusual is that you'll find that the drains will have stopped working, so you should milk them or place them on suction to see if you can get a drainage of the collection. And you need to organize an urgent echo. And you should prepare for urgent chest reopening and exploration. So it's very much a surgical emergency. The other emergency to be aware of is a blocked systemic pulmonary shunt, typically a modified BT shunt or some other type of shunt. And these children present with acute hypoxemia that's usually, that doesn't have any other explanation. There's no pulmonary cause for it. And again, it's being suspicious that this can happen. You need to organize an urgent echo and assess the shunt patency. You want to treat them aggressively with fluids and start heparin quickly. So give a heparin bolus and a continuous infusion. And depending on what the echo findings, you may need to organize an urgent cardiac catheterization to open up the shunt, or surgical exploration if there's no improvement. So what about respiratory management? So the objectives are to get good gas exchange, minimize the hemodynamic effects of ventilation, to start weaning ventilation as soon as the patient is stable, and aim for early extubation or as early as possible and when safe. And it depends a bit on the overall course of the patient. And think about considering non-invasive ventilation or high flow nasal cannula oxygen for infants who've had a prolonged recovery or who have ongoing heart failure after surgery. And one of the important bits about managing ventilation in a post-operative cardiac patient is understanding cardiopulmonary interactions. And this is a bit of a busy slide, but I'll talk you through it. So it basically describes three situations. This is a resting state. This is when a patient takes a spontaneous breath, and this is when we're on positive pressure ventilation. And what it describes sort of the different pressures on the right side and the left side, and also the pleural pressure and the PEEP, and the effects on things like transmural pressure and venous return and preload and afterload. So if you go here to someone who breathes in spontaneously, so they generate a negative pleural pressure, there's no PEEP. So if you look at the numbers here, all the right-sided pressures fall a little bit. So there's an increase in venous return and in preload of the right ventricle. Because the PA pressure drops a little bit as well, the RV afterload decreases. But the effect on the left ventricle is the opposite. So the LA pressure increases a bit because there's more filling. So there's increased, potentially increased preload. And there's also an effect on afterload. So because the pleural pressure is -10, if you look at the left ventricular transmural pressure, let's assume it's 90 minus the pleural pressure, which is negative, so you add 10, so it becomes 100. So the transmural pressure increases. Now, if you look at what happens during positive pressure ventilation, the opposite happens. So positive pressure ventilation, the right side of pressures are increased, the right atrial pressure, the PA pressure. So venous return and preload is decreased, and the afterload, because the PA pressure increases, is increased. So the RV gets a pressure load and gets less preload. But for on the left side, the effects are opposite. Because you've got a positive pleural pressure and you've got a PEEP as well, the transmural pressure now decreases and the afterload decreases. So positive pressure actually makes it easier for the left ventricle as opposed to the right ventricle. So these physiological mechanisms are important in terms of understanding what to do with ventilation post-operatively. So how do we help the right ventricle? And we do that by optimizing lung volume, and I'll explain that taking you through this graph. So this graph shows lung volume on the x-axis, and on the y-axis we've got pulmonary vascular resistance. And if you look at a situation where the lung volume is high, so hyperinflation, there's alveolar overdistension and compression of the capillaries, which you can see here. These are the capillaries, and this is extra-alveolar vessel alveoli here. So you get increased pulmonary vascular resistance, which you see here. In the opposite situation, where there's underinflation, you get pulmonary vasoconstriction because of hypoxia, and also you get increased impedance of the extra-alveolar vessels. And again, the PVR will be elevated. And the optimal point is where you're ventilating at more or less the functional residual capacity. So the ventilation strategy should be aimed to be in this place, which is where you avoid overdistension, but you also avoid atelectasis as well. So that's an important way in which we can support the right ventricle. So what are the effects on the positive pressure on left ventricular preload and afterload? So the left ventricular preload really depends on the effect of mechanical ventilation on the RV output, which I've just described. And as I've shown you before, with the increased mean interthoracic pressure with positive pressure ventilation, you reduce the transmural pressure in the left ventricle, and thereby you reduce the left ventricular afterload. So it has a beneficial effect on the left ventricle. Other effects of positive pressure ventilation are that there's a reduction in intra-alveolar fluid, so oxygenation tends to improve, and also there's a reduction in respiratory worker breathing and oxygen demand. So I just want to mention early extubation, because it's something that is, people talk about a lot, sort of trying to extubate children very early after surgery, sometimes in the OR, or within 6 hours post-operatively, or within the first 24 hours. Now, for most of the experience in this is in older children. In neonates and infants, there is fair experience, particularly with the less complex conditions, where they can usually be extubated within the first 24 hours. And in the reports, which are mostly case series, this is associated with low mortality and morbidity and the reduction in ICU and hospital length of stay. But like I said, they're mostly case series. There are not very many RCTs, and many of the controlled studies do not have very good. They're quite heterogeneous in their design. It is less likely that you'll achieve early extubation in very young infants, and particularly if they've undergone complex surgery or have had long bypass times and cross-clamp time. But there is a trend to try and move the point of extubation forward. It requires an institutional approach and very clear protocols, and also with buy-in from the entire team in terms of patient selection and management. And I've put some references there if you want to have more of a look at that. I just want to briefly mention patients who fail to wean from mechanical ventilation and some of the things you need to think about. So first of all, you need to consider, are there any residual cardiac lesions? So the way to diagnose that is to get echo organized. You may need to organize cardiac catheterization or CT or MRI. The second problem that's not unusual, particularly with children with complex congenital heart disease, are airway abnormalities. And that could be a reason why they're struggling to wean or struggling to extubate. And you can diagnose those by bronchogram, CT scan of the chest, and airway endoscopy. Another complication that can arise is phrenic nerve palsy, and you can diagnose that by ultrasound scan of the diaphragm, and you need to make sure the patient is breathing spontaneously while you're doing the scan. With the very sick children who've been in ICU for a significant period of time, ICU-acquired weakness is not uncommon. You can pick it up on neurological examination, and if available, you can do nerve conduction and EMG, although most of these children have a type of myopathy rather than polyneuropathy, so you might not pick it up. The other thing to think about is that strokes are not uncommon, and again, cranial ultrasound will help you. And think about untreated infection. Children who struggle to extubate, apart from all of the above, think about recurrent laryngeal nerve injury, and again, that can be from airway. I want to mention about fluid overload. We all know is so fluid restriction is very important early use of diuretic. It's not entirely fluid overload. It's not entirely what the cause is. There's too much fluid, not enough drive. When you're dealing with the state, assess if they're no longer responsive, stop giving. All you're doing is making them overloaded without any benefit. And consider early use of increased inotropic support, particularly in the can help.
Dr. Mosley, if I could please ask you to wrap up. We're on our schedule. Thank you so much.
So I'll just talk about hyperglycemia. We don't use hyperglycemic in our unit. To stabilize and unload those. And just to make sure the most common method of supporting them is peritoneal dialysis, and you can use a single which usually works really well, although it's not always consistent. Compromise of cardiac output. We use cross-flow. There are new developments. This leads to the example of and then antibiotics. Very important. Be on the watch for organisms, MRSA, have a local people deal with that. So post-operative care, it's important to understand the effect of the environment, have a clear plan, anticipation of potential complications, monitor your patient closely, and know how to deal with complications as they arise. And what I haven't really it's important to support parents and families throughout the process that it's I'm happy to share my slides for further reading. And happy to take unfortunately we can't travel at this time, but this is why I am in the that's my place of work. Okay. Thank you.
Thank you very much, Dr. Nogner. Thank you. That was a very informative lecture. Thank you so much for your time. So for our next speaker, we have Dr. Naveed Jawed. He's a consultant pediatrician at Surrey Healthcare NHS Trust and an honorary consultant pediatrics cardiologist at the Royal Brompton Hospital in the UK. He has vast experiences in the field of pediatrics. He was trained at the Cardiff University Hospital, the Bristol Children's Hospital, Michael's Hills, and he's a registrar in the general and neonatal pediatrics. He worked at Westminster Children's Hospital as senior registrar and a lecturer in child health at the Royal Free Hospital, and then became a consultant in pediatric cardiorespiratory medicine. He was also the lead for safeguarding children at Surrey. He's a senior examiner at the EMA-RCPCH and a strategic lead for training and examination for the Middle East and North Africa. We're very happy to have him with us today. If you could all give him a warm welcome.
Thank you very much. Can I share my screen?
Yes, Dr. Jawed, you can go ahead and present now. It should be at the bottom of your screen, an option to present now.
Where do I go? I'm sorry.
At the tab at the bottom of your screen, the bottom tab there should be an option to present now. If you select present now.
It normally says
Hello, doctor. This is Ahmed. I'm working with the organizers here, and if you please go to the top right, to the bottom right of your screen, can you see all the participants in the yeah, now. If you click on it, it's going to give you a couple of options. Either to present your entire screen or a tab window. Right? You need to choose the entire screen, please.
Do I share the entire screen with it?
If you can see window, it can be better. So after you click present now, you will have three options. The middle one is sharing a window.
Now what? Sorry. Yeah. Sorry.
Can you confirm that you have the meeting, the conference in front of you and not the slides?
Yes. I mean, shall I go for the entire screen?
If you can choose window and then select your slides.
Okay.
Yes. Select your slides and click apply or share. Whatever button that you can see.
Share.
Please.
I'm sorry. What happened?
Okay. So now if you please go back to your slides and put them in full screen.
Shall I stop sharing?
No, that will disconnect everything.
Okay.
Now just switch back to your slides. Let's not stop presenting.
Well, my slides are on my screen. They are on my. Are they?
Yeah, but they're not shared right in front of us. So may I ask if you have, are you using a MacBook or are you using a laptop?
Mac.
Okay. Can we hit Command Tab, please?
Sorry?
Command and Tab at the same time.
Okay. Yes.
That would switch your screen to the PowerPoint presentation.
Oh. I'm sorry.
No worries. Would you mind if you stop presenting and I do the steps on my laptop so you do after me? Like once I'm done, you have seen what I've done already?
Can't. Why it is not like the normal way?
Let me ask you one last thing. Can you just minimize your screen?
Okay. Okay. Well,
Before stopping the presentation, just minimize the screen.
it is on the screen. It is on my screen.
Yeah, I need you to minimize the conference, please.
Well, it's not minimizing. It's all okay.
The yellow button on the top left.
All right. Yeah, I minimize it. Yes. Hello. I minimize it.
Yes. Someone hit a refresh.
Sorry.
It's not minimized now. Can you please click the yellow button one more time?
Okay.
The left side, yes.
Okay. Yeah, I did.
Great. Does it show your slides in front of you?
Sorry.
Can you see the slides in front of you?
Yes, I can see them. I can see them.
Dr. Please just refresh your screen because it seems like your network is lagging.
Oh. Is it?
Yeah, please.
What do you want me to do now?
Yeah. Okay. Do you want to hit? Just refresh.
Refresh?
Yes, please. No worries. So is there any chance that you can send the presentation and we share it from our end?
Well, it's only, I have only option that says hi. You don't have any thing.
I'm sorry. Okay.
Say stop sharing.
Stop sharing. Stop presenting.
I'm sorry. I would rather Professor Allen, of course.
Let's click stop presenting.
Stop.
Perfect. Now let's click again on share presentation.
Say present now. That's something.
Share.
Shall I?
Present now. Present now. Present now. That's what it says. Present now.
Yeah. Well,
now, instead of selecting the entire screen, just have to select a window, which is the second option, not the first.
Okay. I think it's gonna work for you now.
Okay, that works. Can you now click on the PowerPoint presentation that's already open?
Yes.
Yes. Perfect. We can see it. Now, please go ahead. The stage is yours.
Is it working now?
It is working. We can see it as well.
Shall I start?
Please.
The voice is very clear. Can you hear me?
Yes, we can hear you.
Yeah.
Can you hear me well?
Yes, we can hear you well.
Okay. Well, thank you very much for the introduction, and I'm pleased to be with you. And thank you for the invitation, actually. And I'm sorry, Professor Anne Greenough, I'm not gonna take any of your time. I'll try to squeeze it to 20 minutes, actually. Okay. To make up for the lost time, we're having a hectic day today at the Royal College because we have first EMA-RCPCH examination day. I'm in between, I'm afraid. Okay. Thank you, Abla, for inviting me. I was asked to talk about the community care of children who require either surgical intervention or require long-term care of the community with children with congenital heart disease. I'm just going to go through some just general point. These are the points I'm going to go through. The background, the high-risk groups, post-operative care, which I'm not going to touch, complication and requirement for community. The congenital heart disease are the commonest congenital abnormalities. We used to know that the most, they are the most common, and about 8 to 10 out of 1,000 live births born. But the latest studies, and there's a review of the global and regional impact of congenital heart disease published in the Lancet this year. Hello? Yes, hi. So, hello. Can you hear me? Hello? Can you hear me? Can you hear me? Hello?
Hey, doctor. Yes, we can hear you, doctor.
You can hear me?
What?
You can hear me?
Yes, we can hear you, doctor.
So shall I carry on?
Yes, go on, doctor.
Okay, I'm sorry. Okay.
Okay. Shall we continue?
Okay. I'm going to continue. Something other. So the impact of congenital ranging from 8 to 18.
To move closer to the microphone.
Sorry?
We need you to move closer to the microphone.
Your laptop.
Okay.
Okay. Okay. Thank you, doctor.
Can you hear me?
Yes, I can hear you clearly. Just go on.
All right.
Okay.
I'm sorry. So, with the advances in surgical and non-surgical intervention, there has been a large number or great survival of children with congenital heart disease. And if you look at the graph there, will show. Well, I'm going to go through. I'm going to skip the diagnosis. The diagnosis starts antenatally, actually, and that's first introduced by Professor Lindsay Allen in the late 70s, early 80s, and then from there has been almost every district hospital now have facilities for antenatal diagnosis, and then of course. Significant numbers still missed, of course, with congenital heart disease. So the more reliable diagnostic means are the echocardiogram postnatally, and of course we have other means. We have the MRIs, we have the CT scans, we have various other means. I'm going to have to go rather quicker, on this in order to make up for the time. As a result of there has been lots of advances in non-surgical interventions in congenital heart disease, which helped also improving the outcome of children with CHD. And if you look at the impact of the burden of the congenital heart disease in the 80s, only a small number used to survive to adults or teenagers. Then as a result of lack of diagnostic facilities at that time, there were children who, even with the simple defects, missed and end up with the cyanotic congenital pulmonary hypertension, like Eisenmenger, etc., like this child. But in the year 2000, the adult congenital heart disease starting to take over because of the survival of large children with congenital heart disease as a result of surgical and non-surgical intervention. And this is in 2020. You see the impact. It's a huge. Hence, it is a lifelong journey and not just one-off. Okay, and there's now most Western countries have adult congenital heart disease clinics at not only regional but district, joint district and regional sort of service. The natural history, we said, 1/3 of infants born with congenital heart disease have life-threatening symptoms in the first few days. They do worse than others, of course. And as many as 80% with a critical disease end up with congestive heart failure as a presenting symptoms. They have also feeding difficulties and other problems. But I'm not going to go through the symptomatology and details, because our focus here is what we do. But this is just a screening to tell you how do they present and what problem they might have. The high-risk groups, they are, and as Abla asked me, of course, to touch on the prematurity, and I believe that Professor Anne Greenough will be the right person, well placed to talk about this area, of course, from a respiratory standpoint and from neonatal standpoint, because of her very rich experience and clinical skills. So prematurity and low birth weight pose a major risk and challenge to all doctors, and also children with complex congenital heart disease because of the multiple needs for interventions, and children who are born with not only congenital heart disease but other malformations, and especially when they have a genetic problems, as high as 30% have genetic problems, and those who have delayed diagnosis and complication, when they end up with poor ventricular function or other complications. And in a large study in the Lancet on the impact and the burden of regional and global congenital heart disease, they noted that the low socioeconomic status plays important part in poor prognostic factors. I'm going to touch on this. That's the global, regional, and national burden. And I really advise you to go through this paper, which is very good, published in Lancet in January this year. It showed that the congenital heart disease has caused about 261,000 deaths, with a confidence interval between 216 to 308. That's a global, of course. Okay. Whereas in 2017, of course, a 34.5% decline from 1990 because of the improvement. So in 1990, there must have been, you know, a much larger number, about 750,000 or so. And the most of the death among infants less than the age of 1 year, congenital heart disease, of course, declined as a result of good improvement, but the death increased with the low socio economic the lower the socioeconomic index is, the higher the death, of course. Neonates in low income, as I said, and middle income countries, they with the little access, of course, to the facilities, diagnostic or interventional, led to higher death, and further premature mortality might occur to, of course, secondary and respiratory problems. There was the previous publications put the annual congenital heart disease globally at 1.35 million annual births of neonates with congenital heart disease, and this, to be honest, the congenital heart disease is an increase between 90s and now. You know, this is just like the ISAC study, which shows an increase in asthma. But of course, the two are not related, but it might be related to the socioeconomic status and other and multifactorial. This map shows the mortality per 100,000 per area, per regions, of course, and the highest are in the red areas, where probably Egypt nearly and around this area, I think we touched on this, and the congenital heart disease deaths, you know, occurred in younger than 1 year, and the mortality were highest in the low socioeconomic status. I think I went into this. This is the again in the same, from the same paper in the Lancet, from the same review. It shows the death rate per, you know, globally and per regions, okay, and as per the middle and socioeconomic status. I'm not going to touch on the post-operative at the secondary level. That's whether the tertiary hospitals or these district general hospitals, but go probably later on the primary health care. But we go on the complication and common problems. The complication they run into, these children in the community after they leave the intensive care and at you know, at the community level, that's where we need to focus on arrhythmias, which can be very serious and can have a poor prognostic index if they occur post-operatively. And we have to be very, they are not just like the primary ones, like a child present with an SVT, for example, or when they are post-operatively, they are a little bit more complex and they need good interventions. Hematological, with thrombosis, embolic, or bleeding, heart failure, of course, even post-operatively, even after correction, some of them because of the palliation. An infective endocarditis is a major risk. Infections, of course, of wounds, and in general, because especially if they have other associated problems such as 22q deletion of the George, etc. Neurodevelopmental delay, whether it is as a result of the poor cardiac output or associations or other factors. Growth and nutrition, a major problem, and of course the psychological impact on the child and the family. The growth impairment is directly proportional to the severity of hemodynamic disturbance initially because of heart failure, if they have left to right shunt, of course. Okay, and the cyanotic lesion tend to of course have an adverse effect on the weight gain rather than the height, whereas the cyanotic lesions tend to be both height and weight. They are stuntic, probably, children. Infants with cyanotic congenital heart disease have earlier fall off of the linear growth compared to others, because the left to right shunt can be corrected quickly just with the nutritional, but this is more complex. The adequate nutrition, it is essential for both growth and brain. I don't need to emphasize on this, okay? And but this can be challenging in children with congenital heart disease, most apparent in infants with pulmonary overcirculation. Well, that's the left to right shunt, basically. And they need higher calories, as you know. And some infants with limited ability for oral intake, of course, because of various problems. Injury to the vocal cord, injuries to the, the diaphragm and the surgery, incoordination, associated neurodevelopmental problems, injuries to the airways. They may need NG tube feeding, gastrostomies, etc. Some of them with Fontan, they need the MCTs, etc. Psychological impact are huge, especially in a child with multiple needs and a long term, not just a one-off corrected simple defect. Okay, it can have a major impact on the child and on the family also. I'm not going to go through the details of this. Prematurity poses a major problem, increase the birth prevalence of severe congenital heart disease in very extreme premature infants, and significantly higher mortality also in premature infants requiring operations. So there's some of the missing points here. And of course, there are problems during the intensive care. The premature neonate with congenital heart disease represent challenging. We said they can be quite challenging for clinicians and researchers, and of course, the surgeons. It is not very clear the interaction between prematurity and congenital heart disease is not very well understood. But epidemiologic studies suggest that the premature newborns are more likely to have congenital heart disease, and that fetuses with congenital heart disease are likely to be born premature. I hope Professor Greenough can comment on this with her rich experience. So understanding the physiologic features of this special patient are important. A premature baby, as you know, with all its needs. Now, premature babies with the CLD, with the survival of larger number because of improvement in intensive care, neonatology, and respiratory medicine. resulted in a larger number of children with CLD and who also might have congenital heart diseases. They need lots of intervention, or they are also a challenge to the surgeons and to the future care because of low birth weights, prematurity, and of course associated respiratory problems. The community care, what do you need? As Abla asked, for example, a classical primary care, for example, you need the health officer, midwives, registered nurses, whether of course clinical nurse specialist or community pediatric nurse, community pharmacist, social worker, health promoter, and family physicians. And that's the core there. But of course, in areas with low socioeconomic status or lacking the facilities, you wish for the ideal, of course, but you can't necessarily achieve all the components. And you might be now the advances in technology enabled us to even restrict the if you like, minimize the size or the number of these components because of the advances in technology, providing you have a trained personnel to occupy 2 or 3 other personnel, for example, as a new situation. So, for example, this is an echo with a mobile, an echo facility. So like an echo physiologist and a nurse, you can teach her, and then they can use this. Okay, which many years ago this is almost impossibility. Okay, and this can be used as you see, and can be transmitted through the IT thing. That's an older child, of course. Also, if you see the needs of every child from the prenatal, which apply to the congenital heart disease, to the neonatal, infancy, childhood, and adolescence, slightly different needs at each stage, then you know what is the composition of your team, okay, at that level. But of course, you can in a remote areas, you can restrict this team to 2 or 3 and provide them with facilities, good IT facilities, to communicate with the big centers. This is, for example, a classical active implementation of pediatric congenital heart disease management program. It is rather busy, and I will leave it to you to to talk about the resources and policies, management, the delivery system design, clinical informations, all sorts of these. That's within this the health system, and that's the community. The minimum component, ideally, to be honest, you need there is the primary health care. That's a GP in your area, health visitor, that's deal with the growth and immunizations, community pediatric nurse, and we have in UK CNS. You see the advances in Western countries and UK and USA, for example, it was because you have an integrated unit, and also good communication between the community, district level, and the tertiary centers. So you don't have interruption of this important link. Okay, so you need so we have a clinical nurse specialist who's a nurse trained for at least minimum 1 year after that in her specialty, whether in neurology, in cardiology, anywhere, diabetes, at least minimum 1 year. But you can have a community pediatric nurse in your area. A nutritionalist is very important because of the problems I just mentioned. Social worker, because you had lots of problems with these children with long-term needs, and of course communication facilities within IT, as I mentioned to you. The role of pediatric nurse and health visitor, routine health maintenance visit should be scheduled, evaluation, congestive heart failures, routine immunization, because they need immunization, some of them even earlier than other children, and full immunizations, and certain contraindications also if they have T-cell deficiencies or other associated problem, as in 22q deletion. Other associated abnormalities they can have, they can have genetic problems, and they have even more needs, and of course the nutrition, which we talked about. I only put the suspicion of cyanosis should be confirmed by pulse oximetry, because there were several studies in the past showed that high ethnic minorities, and I believe in Egypt you have, and in Aswan you have children with dark skins. It's difficult sometimes to diagnose the cyanotic congenital heart disease without pulse oximetry, so it can be easily missed. Also, among the facilities we use, and in order to enable your team to communicate with the tertiary centers, is the video calls or the mobiles, for example. We use also telemedicine, and that's Professor Swinfen. Professors, when they have Swinfen telemedicine here, where they have several hundred units all over the world with a very simple devices of a camera with, of course, consent, and you take consent of the patients, and then you take photos, and you download all the CTs and images, etc., and send it to a certain email, providing you are part of the whole system. So to take home message at the end, the congenital heart disease is a lifelong journey, and just not one-off. Premature children are at a higher risk of complications, and they need, therefore, their needs are higher. Care at the community level remain essential in order to improve the outcome. But you can start with a small team and aim for the most ideal. The structure can be started, as I said, with simple and aim for a bigger one. I'm sorry for the initial problems. Thank you very much. Are you with me?
Thank you, Professor. Thank you very much for your informative talk, Professor.
Hi, Majid.
Hi there.
How are you?
Fine.
Thank you very much for the wonderful presentation. It will help us a lot with stabilizing the community support group for babies, graduates for perioperative care.
Thank you very much.
Sorry?
If you haven't, I'll send you my slide.
If you please, if you send it to me, it would be great.
Absolutely, I will send them.
Thank you so much. Thank you. I'm very sorry for keeping you waiting and, delaying for your work. I know how busy is your agenda.
Thank you very much.
Thank you. It was great. Thank you very much.
How can I
So we are now going to go back to our live transmission from the Saeed Batara NICU and see the updates.
Hello? Dr. Mahmoud? Okay. We can talk to Dr. The director?
So just to let you know that what happened is that they stabilized the case, and currently the doctor is getting some lab tests because they have run multiple lab tests, and they have stabilized the case, and they are getting ready to join us in a minute.
Yeah. لا لسه عملوا انت ولنو جرينو عملت اللي هي بقى وخلاص احنا انتظرنا الياس. السلام عليكم يا دكتور. اهلا وسهلا حضرتك، يا ريت حضرتك تدينا الابديت بتاع الانفستيجيشن بتاعته.
بعد ما خلصت الكونفولجن احنا ادينا له ايبانوتين لودنج وادينا دوز مغنيسيوم سلفيت، وبدانا هنمشي بعد كده على الايبانوتين مينتنس. وفحصنا اي بي جي، اخد عليه بايكارب واخد نورمال سلاين. الاي بي جي امان كده. البي اتش طالع 27، الاتش سي او 3 6، البي سي او
6، الاتش سي او 3 6.
نسحب اي بي جي دلوقتي.
تمام. كان الكوز بتاع السيفير ميتابوليك اسيدوزيس ده كان له اي اكسبليشن في الانفستيجيشن السبتك اور سامثينج؟
سحبنا الالكترولايت دلوقتي، بس هي لسه سحبنا
Can I know his blood glucose? Okay, it was normal. And BCO2, how much was the BCO2? How much?
خالص مفيش وصل الثاني.
كان كام يعني البي سي 2؟ لان حضرتك بتقولي البي اتش 7.27 والباي كارب اتس اونلي 6، ده معناه ان هو لازم البي سي 2 يبقى واطي شويه، يبقى هايبر فنتيليتد شويه عشان نقدر نحافظ على البي اتش بالحجم دوت مع باي كاربونات اوف 6. How much was his BCO2? بس thank you very much for his stabilization. يعني I can see ان هو الconvulsion aborted completely.
تمام.
So what is your plan with him? What's next?
يعني حضرتك collect the data ونرجع تاني عند الميكروفون لان احنا سامعين حضرتك كويس.
is demonstrated well in spite ان الجهاز ده لسه متركب قريب، لكن it can give us a lot of information about the baby, about the equipment, about what is going on around. ممكن يعمل communication بيننا وبينها، نناقش الحالة، نحط plan for management، نعمل follow up. وده التارجت اللي احنا we wanted to show ان احنا بالنيو advance of net in teleNICU we can help each other while we are distant away, and it can happen 24/7. And this is the advantage of having the NICU, and we were really proud that with the cooperation من هيئة الرعاية الصحية في بورسعيد ان هم ساعدونا في اننا نشتغل مع بعض ونقدر نعمل نيو سيستم ممكن بعد كده نستخدمه في محافظات اخرى وفي قرى اخرى. Anything else you want to tell us يا دكتور؟ لو سمحتي في أي معلومات تانية حضرتك تقوليها لنا؟
تمام، احنا سحبنا سي جي تاني.
أيوه.
بي اتش 755.
55.
الاتش 3
كام؟ بي سي او 2 كام؟ 5. البي سي او 2 5؟
ايوه.
لا حضرتك شوفي كويس.
البي سي او 5.
حضرتك قليلي البارامتر بتاعت الفنتيليتر، البايكارب كام؟ وعلى كام فنتيليتر البارامترز؟ كام؟ البريشر كام؟ بيب 4 والباب كام؟ بريشر كام؟ حطها احنا محتاجين ننزل شويه بريشر وننزل بالريت ونكت داون على التايدال فوليوم شويه. البيكربونات بقت كام؟ كام يا فندم؟ أنا مش سامعة حضرتك. البيكارب كام؟ البيكارب 4 والبي سي 2 5. لا في حاجة غلط. لا I think حضرتك جمعي عينة تانية واعمليها لأن أكيد في يعني السامبل ما كانش sufficient enough for the test. تهيألي لأن 4 و5 ده incompatible with life في الحقيقة. وما ينفعش يبقى البي اتش 7.55 مع بيكربونات اوف 4 فاكيد في مشكله في السامبل. فيا ريت حضرتك بس ورم ذا لمب وهاف انذر سامبل اند سند ات فور ذا لاب، وممكن نتواصل بعد كده نبص عليها مع بعض. بس مين وايل حضرتك هتنزلي شويه زي ما اتفقنا الريت والبريشر والتايدال فوليوم لغايه ما نتقابل تاني بعد العينه الثانيه بتاعه البلاد جاز. ربنا يخليكي، ميرسي جدا تعبناكي. هنتظر من حضرتك اتصال تاني كده كمان بعد ما النتيجه الثانيه تيجي.
تمام.
الف شكر لحضرتك. حضرتك عايزه تساليني على اي حاجه؟
تمام، هنسحب الاي بي جي.
شكرا. السلام عليكم.
يعني قرني انا
فعلا عشان
لا هي مش
Thank you, Dr. Dr. Majid, thank you for your time. If you'd like to sign off or turn off your camera now, you may do so.
Hello, Dr. Jawad, can you hear me? If you please unmute yourself. Dr. Jawad?
The person who called you Rania Shirbini, apparently there's a case,
رانيا
Shirbini.
شايفين
And
ولا أنا المشاط
No,
الوكيلة
something Shirbini. No. She's
Mm.
asking about if you go to Mansoura or not. Apparently there's a case. Yeah. She sends you an email? Anne sent an email right now and said that she got exited out of the meeting and she was trying to get back in. She didn't leave the meeting. She's saying she said she can't get back in. Okay. طب خلاص did she ask to join ولا لا؟ أو مش عارفين؟
من فضلك مش لازم تدخل.
Do you want me to write her a response?
Sorry for the pause, everyone. We're trying to get a video for one of our speakers to show it's pre-recorded. It's for Professor Ann Reno, and that's what we're trying to display on the screen right now.
اه يتغذى لكن الاوتيل الثاني في كده خلينا الاول استنى القعده.
experience.
طيب دكتور عبلة we need ده كله silent time طلع public.
This young lady was pictured by different treatments of information. She's pictured, however, discharged and you see that she's wearing as a candidate. That is, she is diagnosed. So every definition, she was suffering from alcohol disposal, which is the cause of this outcome of the birth. discussion is a meta-analysis of 6 papers of with no compared to term controls. In Europe, in EPD infants are around 10%. But when we looked at the severity of bronchial dysplasia, those with the most severe had almost 19% reduction. This is another study looking at lung function at 19 to 11 years in 163 infants all born below 33 weeks of gestation, and 99 of them had bronchopulmonary dysplasia. They were compared to term controls, and CT scans were performed in those born preterm. Again, the preterm children, I should say, compared to the term controls, had pulmonary obstruction and hyperinflation. But more importantly, ladies and gentlemen, I'm delighted to be asked to talk to you about long-term respiratory consequences of being born too early. But I'm extremely sad that I cannot be with you in your beautiful country. This young lady was pictured her surviving at 22 weeks of gestation. She's pictured, however, on the day of discharge, and you will see that she's wearing nasal cannula. That is, she is requiring home oxygen. So by everybody's definition, she is suffering from bronchopulmonary dysplasia, which is the commonest adverse outcome of very premature birth. This is a chest x-ray of another baby. As you will see, at 30 days, this baby is ventilator dependent, is requiring total parenteral nutrition. You can see her long line in situ, and has a very, very abnormal chest x-ray with interstitial shadows throughout and cystic shadows more prominent at the bases. Again, definitely this baby has got bronchopulmonary dysplasia. And when you look at this x-ray, there is no, it's very clear she will suffer long-term respiratory problems. But what are they? Well, this is a study looking at school-age lung function, 11 years of age, which showed reductions in airway function, difficulty in breathing out, and reductions in diffusing capacity, i.e. Less gas exchange areas. In the discussion, the authors made a meta-analysis of 6 papers and found again FEV1, forced expiratory volume in 1 second, was lower compared to term controls in the BPD infants by about 10%. But when they looked at the severity of bronchopulmonary dysplasia, those with the most severe had almost 18% reduction. This is another study looking at lung function at 19 to 11 years in 163 infants, all born below 33 weeks of gestation. An increased risk